Ma'am, we can live and as well as delegate are also join, so we can start now.
Yeah. Because there are only 11 attendees, so we are just waiting for 1 or 2 minutes.
Now it's 19 now. Yeah.
8 of us.
21. Yeah, it's going up.
Usually they are a little bit late, our group.
23.
5 minutes.
So it's going up fast. I always believe we shouldn't punish the early comers.
Absolutely. We can start, Divya.
Good evening, everyone.
Don't put the slide now only.
So, on behalf of Indian Society for Pediatric and Adolescent Endocrinology, I welcome everyone for this 18th series of academics and clinical education series. I am Dr. Divya Lakshmi, pediatric endocrinologist from Sri Ramchandra Medical College, Chennai. So, we will start the program now. I will now invite Dr. Shaila Bhattacharya, President, ISPAE, Professor, Department of Pediatrics, JJMMC, Davangere, and Pediatric and Adolescent Endocrinologist at Shiv Jyoti Clinic and Manipal Hospitals, Bangalore, for the welcome note and to start the program. Shaila ma'am, over to you.
Yeah. Thank you, Dr. Divya. Good evening, everybody. Nirav, I'll ask you to put the slide. Good evening, everybody. I welcome our international speakers, Dr. Khalid Hussain and Dr. Senthil will be joining us soon. And special thanks and invitation for Dr. Mohan, all three of them for accepting our invitation for this meeting. Just to tell briefly, Dr. Khalid, we have been doing monthly academic meeting for last 1.5 years. Every month we have 2 speakers talking on the subject and 2 case presentations presented by the fellows or the trainees, and the mentors will be our national speakers faculty. So this is our 18th one, going on very well. So this month we have neonatal diabetes and obesity. So the first half, the first 1 hour will be discussion about neonatal diabetes. For that, we have the first case presentation by Dr. Shankar Dangel. He is working as senior resident in Chacha Nehru Bal Chikitsalaya in New Delhi. He has done his MD Pediatrics from PGI Chandigarh, and his mentor is Dr. Medha Mittal. And to discuss this case with him is Dr. Mohan. Can you put Dr. Mohan's slide, please? CV slide. You know, we all know Dr. Mohan very well. He is our next slide, please. He has done his MD FRCP. He has got so many degrees. I think other 1 full hour will go on description of his CV. So to be very short and sweet, he's been authority in neonatal diabetes in India, I would say. And we are very blessed because he's in South India, and any difficult problems, difficult cases, and to do a lot of research work, to do genetic mutation studies, he is always there. Just a call away, he and his team are always there for us. I don't think I want to go anything more than that. He has got a lot of awards. He has been the best student, best scientist, so many things. Along with that, he has been also awarded Padma Shri from Government of India in 2012. And he has authored the book Making Excellence a Habit, published by Penguin India, and Banting Bows and Beyond, published by Notion Press, which are bestsellers on Amazon. Thank you very much, Dr. Mohan. Welcome to this meeting. So we'll start off the case, first case, Dr. Shankar, please.
So maybe Dr. Shankar can present now. Yeah.
Yes, thank you, sir and ma'am. I'll just share my screens. Ma'am, are the slides visible?
Yes.
Yes, yes.
Show mode, huh?
Make it slideshow.
Yeah. Is
Yeah.
it okay now?
Yeah, fine.
Okay. Good evening, everyone. Today, I will be presenting an interesting case of neonatal diabetes. I'll start with the history of the child. My patient is Master P. He is 6 years, 3 months old now, resident of Mukherjee Nagar, Delhi. He first presented to us at 3 months of age with fever, fast breathing, refusal to feed, and altered sensorium. He had fever for last 3 days, presented with fast breathing in the form of increased rates and depth, but not associated with cough or cyanosis. He also had altered sensorium in the form of lethargy and decreased interaction. There were no history of seizure, cough, or diarrhea. He was born out of second-degree consanguineous marriage, and there was no history of diabetes in the family. He had uneventful antenatal history. He was a full-term normal delivery with a birth weight of 2.5 kg, that is average for gestational age. He cried immediately after birth, and postnatally he remained well till 3 months, and he was exclusively breastfed. He was immunized up to date as per national immunization schedule. At 3 months of age, he had partial neck holding and social smile was present. This is the family pedigree showing second-degree consanguineous marriage. At the time of examination in emergency at 3 months of age, he presented with severe dehydration in altered sensorium. He was having tachypnea, but it was more of acidotic breathing, and he was in compensated shock. On systemic examination, he had altered sensorium with reduced tone, and tendon reflexes were absent. So at trials, we investigated the child, and he was found to be having high random blood sugar with high anion gap metabolic acidosis, with a VVG with a pH of 6.9 and bicarb of 4. Urine was positive for ketones, and there was elevated TLC count of 27,000 with a positive C-reactive protein. So initial possibility at admission, we kept as DK with sepsis. For respiratory failure, we had to intubate the child, and he was later mechanically ventilated in PICU. For diabetic ketoacidosis, we managed the child as per the guidelines of ISPAE, and for sepsis, he was continuing with IV antibiotics. However, by date 3 of hospital stay, the child became oliguric and edematous, and his investigation was showing worsening renal function test with the creat maximum going up to 2.1. So possibility of AKI was kept, and child was started on peritoneal dialysis in PICU. He required peritoneal dialysis for 8 days, after which urine output improved and his creatinine also improved. For respiratory failure and sepsis, we continued with supportive management. We were able to make him off ventilation by day 7, and we stopped the antibiotics by day 10. So neonate child presenting with hyperglycemia, and he had persistent insulin requirement even after resolution of sepsis. So we kept the possibility of neonatal diabetes mellitus, and in view of consanguineous marriage, we sent the sample for genetic analysis to University of Exeter, and they primarily analyzed for 4 genes: KCNJ11, INS, ABCC8, and EIF2AK3. And the child was found to be having homozygous mutation in EIF2AK3 gene, and parents were found to be having heterozygous mutation, both mother and father. So final diagnosis of Volcker-Dilaton syndrome with AKI with sepsis was made. The child gradually improved and started accepting breast milk. So then we converted from insulin infusion to subcutaneous insulin, as KCNJ11 and FCC8 was negative, so there were no roll of sulfonylureas. We evaluated the child for thyroid function test, liver function test, and TTGA, which were normal limits. At the time of discharge, HbA1c was done, which was 11.6, which further supported the diagnosis of diabetes mellitus. Skeletal survey was done, which showed no abnormality. Ultrasound showed mildly increased kidney size at that time. The child was discharged on regular NPH insulin and was kept for regular follow-up. Since we considered the possibility of Volcker-Dilaton syndrome, we were following up the child to look for evolution of any other associated features that I will be discussing later. So we followed up the child with for his glycemic control, thyroid monitoring, growth and developmental monitoring. In between, he had infrequent follow-up for around 6 to 8 months, but then we again catch up the child at around 3 years of age. So at 3 year of age, TFT was found to be deranged with TSS borderline low, FT4 low, and FT3 was low. So central hypothyroidism was labeled, and child was started on thyroxine at 25 mics. As a part of workup for central hypothyroidism, we did MRI brain, which showed normal size and position of pituitary gland. Similarly, serum cortisol, basal, and post-HCTS was also normal. So only isolated central hypothyroidism was considered, and this hypothyroidism is one of the feature associated with Walker-Dalton syndrome. So we continued hiking thyroxine as per his TFT report. The latest TFT as of July is with the TSS of slightly elevated TSS 5.15, FT of 0.9, and FT3 of 3.46. Currently is on thyroxine at 75 mics per day. Again, developmental delay is another association with Walker-Dalton syndrome, and this was found in our case also. As per his milestones, latest milestones, he is having developmental quotient of around 50%, social quotient of 70%. His hearing and vision are normal as of now, and there are no other behavioral issues. Again, skeletal dysplasia is a very known association of Walker-Dalton syndrome. It's one of the main criteria for diagnosis of Walker-Dalton syndrome, and we are following up the child for that. However, this was noted at around 3 to 4 year of age, where we did skeletal survey, and it was suggestive of multiple epiphyseal dysplasia or spondyloepiphyseal dysplasia. I will be showing in the subsequent slides. So this is the X-ray of the lung bone. We can see here the epiphysis of the femur is very small. I'll be showing a X-ray of a normal child in the subsequent slide. Then it will be more prominent. So this epiphysis is very small. The acetabular roof is also flattened. We normally expect a cupping of acetabular roof. Similarly, at the lower end of femur and upper end of tibia, again the epiphysis is small. It is sclerotic and it is irregular border. Again, here we can see his vertebra. It is more flattened vertebra. The height is small as compared to a normal child of the same age group. This has been discussed with the radiologist in our department. So here, this was the X-ray which was done at around 4 year of age, and this is the recent X-ray done 1 week back, which is again showing the similar findings. We can see on the left side X-ray of a normal 6-year-old child. The femur is showing well-formed epiphysis, and the cupping of the acetabular roof is also well-formed. But in our child, again, the epiphysis is very small, and this cupping is not formed because the epiphysis is not developed, so there won't be any cupping of. So it's more a flattened epiphysis. Similar finding is seen in spine. Even now, at the spine height, the height of the vertebral body is small. So these findings are suggestive of spondyloepiphyseal dysplasia. Chronic kidney disease is another association, systemic association of Walker-Dalton syndrome, and we are monitoring the child for that. The child continued to have deranged RFTs with persistent hyperkalemia. Ultrasound, which was done last 6 months back, was suggestive of small kidneys with medical renal disease. So these are the latest report as of July 2022, which showed persistently deranged RFTs, persistent electrolyte imbalance in the form of hyperkalemia, and normal anion gap metabolic acidosis. And his estimated GFR, which we calculated, was 50 ml per minute per 1.73 meters square. So he labeled him as CKD stage 3A, and he is under nephro follow-up. Short stature is another known association of Walker-Dalton syndrome, and this is the latest anthropometry of this child done in July. His height is around 86 centimeters, which stands at almost minus 6 Z score as per IAP chart. Short stature is also noticed in our child. Rickets profile was done, which is within normal limits. For diabetes mellitus, there were no any further episodes of DKA. Initially, the child was on NPH and regular insulin till 1.5 to 2 years of age. Then after we changed to regular insulin and glargine. Currently, he is at 1.2 unit per kg per day insulin, and his RVS are well controlled. His last HbA1c was done in June, which is 7.7, which showed that the glycemic control is good enough. So this is the table, which on the left side shows the association, systemic association of Walker-Dalton syndrome, and whatever are ticked are present in our index case. Now we are monitoring the child for hepatic dysfunction routinely. we were planning in view of poor growth and short stature. Though there are no clinical evidence of any pancreatic dysfunction in the form of loose stool, but because of poor growth, we are trying to do fecal elastase to evaluate pancreatic dysfunction. However, parents were not affording, so we were not able to do. Neutropenia, few reports of neutropenia are seen in cases of Walker-Dilaton syndrome. However, in our case, there was no neutropenia. So this is the slide showing the current issues, what is the current status, and what are the ongoing intervention, and what are the plan to follow up in our index case. The parents, they have a second child who is a girl, and she is 3.5 years of age. Antenatal genetic counseling analysis was done from AIIMS Delhi, which was found to be normal. So the currently child has no issue. They are also planning for next pregnancy, and they have been adequately counseled regarding the possibility of similar illness in other child. Few slides regarding neonatal diabetes mellitus.
So what I suggest, since it's interest of time and since Dr. Khalid is going to discuss this, you talk about WRS alone. This neonatal part, we'll leave it to the next speaker.
Yes, sure, sir.
All this will skip and go to this here you can talk.
Yes, so Walker-Dilaton syndrome, it's a rare syndrome. It's autosomal recessive inherited systemic disorder. It is neonatal insulin dependent diabetes mellitus with skeletal dysplasia in the form of epiphyseal dysplasia, as I have discussed in my case, with variable presence of other systemic association in the form of hepatic dysfunction, renal dysfunction, exocrine pancreatic insufficiency, neutropenia, developmental delay, and growth retardation. It is caused due to mutation in EIF2AK3 gene. This gene is predominantly localized in pancreas and bone. So diabetes mellitus and skeletal dysplasia is a must finding in this syndrome and can have another systemic association. So whenever there is a case of neonatal diabetes mellitus in a consanguineous pedigree, this is the most common syndrome associated. So we must work up for Walker-Dilaton syndrome in such case. It's a rare entity. To date, only 60 to 65 cases have been reported worldwide. Other thing is there is possibility of detecting other features, other systemic features later on life. So we need to routinely follow up this side, as seen in our index case also. So this is a slide showing how to approach.
Probably this also will skip because it will take time. Go to the next one.
So these are this one is a case series which is they have evaluated 34 probands and 26 mutations were detected. This is from Indian series in which 40 patients of infantile onset diabetes mellitus was studied. Out of which 9 had features of WRS and 4 were genetically confirmed to have Walker-Dilaton syndrome. So final slides, learning points. Neonatal hyperglycemia could be because of hypertonic dehydration, sepsis, or due to neonatal diabetes. Transient neonatal diabetes and should be differentiated. It has certain clinical features in the form of small for gestational age, umbilical hernia, and the most contrasting feature is transient neonatal diabetes doesn't present with ketonemia or ketonuria. Neonatal diabetes in a consanguineous marriage with skeletal dysplasia, we have to work up for Walker-Dilaton syndrome because it's the most common one. And systemic association in Walker-Dilaton syndrome may not be present in infancy, so a regular follow-up is advised. So lastly, I'd like to thank my faculty, Dr. Medha Mittal, who has been managing this case for the last 6 years, and Dr. Natasha Gupta, who has given us input for radiological and skeletal survey. Thank you.
So, Divya, if I can just share, can stop sharing. Shankar, that is a fantastic presentation. I'm just going to come back to that. I just wanted to show 3-4 slides with your permission.
Yes,
and I hope this is visible.
Yes.
Yes.
Okay, so I just had, oh, what happened? Why isn't? Okay, so I just wanted to share our experience with this. You already quoted one of our studies with Dr. Puvarigi from Institute of Child Health. Now, I just wanted to tell those who are not aware that we have a monogenic diabetes registry. So you just go to www.monogenicdiabetes.in. It'll give you all details about MODI, neonatal diabetes, how to send the blood, and everything is how to get the consent form and so on. We are a nodal center. The Madras Diabetes Research Foundation is an ICMR nodal center for monogenic diabetes. We get samples from all over the country, including several from Delhi. So next time, Shankar, you don't have to send it to Exeter. We follow the exact protocols that Exeter, in fact, we're trained in Exeter, and even the reading is done exactly the same. So this is our total experience with monogenic diabetes. 1,562 cases have been referred to us so far, of which the vast majority are MODI, but not all are clinically proven MODI. These are the proven MODI cases. We have MODI 1, MODI 2, MODI 3, MODI 5, the whole thing, MODI 12, and so on. Neonatal diabetes, 315 cases have been referred to us so far. of which ABCC8 is the commonest and KCNJ is the next common. Again, the next speaker is going to talk about that. But note that INS gene and others are also there. Syndromic forms is what we are interested in today. And WRS, I'll show you in the next slide. These are all the syndromes which we have picked up at our center. Also wanted to mention in passing that as common as neonatal diabetes is congenital hypoglycemia. Much more difficult condition to treat. If you ask me out of all of these, which I would be happy if somebody, one of my relatives got neonatal diabetes, especially KCNJ11 or ABCC8, because you can just give sulfonylurea and you're done, okay? Syndromic, bad news. Congenital hypoglycemia is also terrible news because it's very difficult to treat. And that's a list of the syndromes that we have, 59 cases so far, of which you can see 27 are WRS. So the 60 cases which you're saying, it is in a report which was published in 2010. I'm sure there are hundreds of cases in India itself. Many must be getting missed because who does the testing and who looks for skeletal? I saw Divya had already asked, why are you taking a skeletal survey? You have to do it because by the first year itself, you can pick it up. And that's one of the, even before the genetic testing comes, you will see that the skeletal is one of the early abnormalities. And it's also the commonest, 38% of all the syndromic form is WRS or Walcott-Rollison. But Wolfram syndrome is not far behind. You have 16 cases of DID mode, diabetes insipidus, diabetes mellitus, and optic atrophy and deafness. And then, of course, you have MIT and thiamine responsive and all kinds of other syndromes also there. So in neonates, this is not the only type of diabetes that you see, and only by making a diagnosis, you can treat that. And some like thiamine responsive megaloblastic anemia, you just give thiamine and the diabetes goes away and anemia goes away. It's fantastic, you know. So this is precision medicine at its best. And that is why I think all neonates, you should consider if they have diabetes, whether they have some other form of diabetes, because the prognosis is totally different. So with that, I'll stop. And now we'll ask some questions. A couple of things from my side. One thing that was not fully emphasized by Shankar is the poor prognosis. So the reason why I said, you know, when Dr. Raghupati, we are having a meeting in March 5th, which Shaila also attended, Raghupati was saying, every time I send a blood sample to MDRF, I pray that it's neonatal diabetes ABCC8 or something, or at least if you find a mutation. So something can be done. Whereas at the same time, if you find Walcott-Rollison syndrome, very rarely they live beyond 18 to 20 years of age. By the 18th birthday, they're dead. 1 or 2 cases have been reported at 30, 32 years, but that's in the whole world. In biology, nothing is 100%. But almost 99, 98% of children die before they reach adulthood. And they have a terrible disease. Neonatal diabetes is so simple. You just give them sulfonylurea. After 20 years, they're fine. They very rarely develop retinopathy also. They have 40-year follow-up showing that very few of them develop retinopathy or nephropathy. Whereas here, life itself is in danger. Imagine kidney disease, liver disease, dysplasia, growth retardation, mental retardation, microcephaly, everything you can think of. One of the worst diagnoses that you can get is Walcott-Rollison syndrome. So we should pray that they don't. Now, this consanguineous marriage is one of the biggest causes, and certain communities have a lot of them. And in some families, I've seen 2-3 cases coming. And any child which dies, if they say that, because neonatal diabetes doesn't kill people, they'll give insulin, something, even sulfonylurea not given, they may survive. Whereas if you find that, oh, earlier child also died and so on, think of Walcott-Rollison syndrome. That's one of the things which gives you. And Divya, you should do an X-ray of the thing because early skeletal dysplasia is one of the early signs, even before you do genetic testing. And that's fairly specific of Walcott-Rollison syndrome, not seen in the other types. I think quite rightly they have done that. So I'll pause here and then we'll ask other questions. Why was skeletal survey that you did? Short stature, is it due to skeletal dysplasia or hormonal deficiency? Shankar, would you like to answer that?
Sir, I think it was, it's more of because of the child is also having hypothyroidism. That is also
not in this child, in general, because they're short statured, no? So
that is been described in an association with the mutation. So
I think the direct answer is it's due to skeletal dysplasia. When you've shown such gross skeletal thing, there's not even formed, acetabulum is not formed. Naturally, they're going to be stunted. And the typical, the waddling kind of gait, the duck-like gait and all that have been classically described, the varus, the deformity and so on. Of course, they could have hormonal deficiency as well. And of course, central hypothyroidism is also there. The 6Q24 is specific for transient neonatal diabetes. So that is definitely covered. In our panel, we have 78 types of monogenic diabetes, all the 14 MODY types, all the types of neonatal diabetes, about 8 or 10, including GATA, insulin, all of them are covered, PDX and all of them, plus all the genetic syndromes are covered. Even if one case has been reported in the world, we add it to our panel. So nothing gets missed out. And now for questions, if you go, Dr. Upadhyay wants to know, HbA1c in a neonate is not very reliable due to transition from fetal to adult. So what do you say, Shankar?
Yes, sir, I agree. Usually we have to do fructosamine, but we did this at around discharge of the child. He presented to us at around 3 months of age, and by the time he was discharged, he was around 4 months of age. So
I think it is still
keeping that
reliable.
in mind,
So the answer is yes, it is still reliable, because in neonatal, they come with, even at 3 months, 4 months, they come with elevated HbA1c. Even given that some part of it is fetal, it is still quite, because the A1c is so high compared to the normal. In Walcott-Robinson syndrome, liver rearrangement is a common cause. What is the prognosis and expected life? I think we answered that. Expired due to 6 years of age. The best you can get is about 15, 16, 18 years. I don't think beyond 18 years, except as 2 case studies, they've been reported. Adulthood, growing into adulthood is almost unheard of. So that is why if the parents are planning to have another child, they can go ahead, but there's no guarantee that the next child won't have it. But then in utero itself or at birth, you can rule out. And then if they don't have this mutation, also called as PERK mutation, BAF1K2 is also called as a PERK mutation. So if they don't have it, then the child is safe. So very often as part of genetic counseling, we tell them, go ahead and have one more child because this child may not live. Then the IPEX syndrome, 2 cases, they were referred to us and they have their own clinical features. Each one of these has its own clinical features. Dr. Radha Venkateshan is here, and as she has said that we cover all the genes like Exeter. So entire whatever gene is there discovered in the world from the thing, it's Dr. Radha and her team who do that, and we do it free of cost, by the way. So you don't have to say, oh, private center, they will charge. We won't charge you 1 rupee, and in 3 weeks to 4 weeks, Radha and team will give you the results much faster than what Exeter can give you now. Okay, and unlike Exeter, where they do 4 or 5 genes, we do all the genes. 78 genes we cover. Okay. Any other questions from anyone? We are 1 minute more to go. So I've kept Shankar and I have kept the time.
Lastly, any experience with the bilateral hip dysplasia, surgical repair to improve gait and pain? And
the genetic defect, what can you do? And the survival, you're talking about WRS.
I think so. Yeah, Sarah is talking.
What are you going to do? Survival itself is not there. So how frequently have you seen mutation negative NDM and later as type 1 diabetes? Well, they are not type 1 because the GAD is negative, zinc transporter is negative, they have a little bit of C-peptide, and onset below 6 months of age in type 1 is extremely rare. But having said that, not only here in Exeter also, if you take all cases of NDM, let's say you take 100 cases of NDM and we listen to what Dr. Khalid has to say, only about 35% actually have any mutation. Then some may have the genetic syndromes and so on. In 50% of the children, we're not able to find the mutation. So then you need to do exome sequencing or whole genome sequencing and so on, which is not easy to do, but that is the next phase. In fact, literally in the next 2 days, we have the extension of our ICMR project. And that's exactly what we're saying. What are we doing with all these cases where we have not found the mutation? Is there something, we ruled out the common ones, but they're still getting diabetes at that age. So, and all such cases we treat with insulin only, because until proven otherwise, we can't give them sulfonylurea. But what do they have? So now is the time to discover new, and so become part of the registry and send in your cases, because we must build up the large Indian registry. See, one in about 100,000 to 200,000 cases in India have neonatal diabetes. Considering the number of 25 million new childbirth every year, we should be having 100 to 200 neonatal diabetes every year. We're not even having that in the whole country now. Okay, so somewhere we are missing, and I'm sure Dr. Khalid will also refer to that. They are missing. They may not even do a blood sugar for the child, and the child may be dying without even diagnosis. WRS also may be missed. because the child may die of renal failure or something in the first or second year before they've done an X-ray or thought of doing genetics. So since the kind of infection that they had in Shankar's case, sepsis and so on, how many of those children survive? So many cases will still be dying. So we have to keep our eyes and ears open. The role of sulfonylurea trial in mutation negative cases, don't do it. Because if they have some other mutation, even if they have an insulin gene mutation or a GATA mutation, they need insulin. Only KCNJ and ABCC8 respond. Luckily, they are the most common. And they respond beautifully to sulfonylurea. So don't blindly say below 6 months, so we won't, we'll stop insulin and try tablets. It can be medical legal. So you have to do genetic testing. When somebody is doing it free of cost for you, why are you worried? Send a sample across and do it scientifically. Okay, we are exactly on time, 7:30. So I'll stop here and thank Dr. Shaila, Divya, and Hari and Shankar for that beautiful presentation. Keep looking for more cases, Shankar. I'm sure if you find one, you'll find many more. Write up the series, and even this single case, document it. Because then they'll keep saying 60-60. Even after 10 years, they'll say only 60 cases in the world.
Right, sir.
It is not true.
Yes, sir.
Okay.
Thank you, sir.
Thank you. I'll stop there.
Nirav, please share Dr.
I'll introduce Dr. Khalid Hussain. Yeah. So it's a great pleasure now for me to introduce Dr. Khalid Hussain, who is an MBBS, MSc, MD, MRCP, MRC PCH, Professor of Pediatrics at the Weill Cornell Medicine at Qatar and Division Chief of Endocrinology, Department of Pediatric Medicine, Division of Endocrinology, Sidra Medicine. He's a Program Director for Research for Children's Clinical Management. He underwent his training in England and was formerly consultant pediatric endocrinologist at the Great Ormond Street Children's Hospital, the world famous children's hospital. He has more than 20 years experience. His research focuses on epidemiology. He's an internationally recognized expert, more than 300 peer-reviewed publications in NEJM, Nature Genetics, Science, etc. You're all eagerly listening, waiting to listen to Dr. Khalid Hussain, who's going to talk about neonatal diabetes. Over to Dr. Hussain. Dr. Hussain, you can
I share my screen?
You can stop sharing and allow
Yeah,
Dr. Hussain to share. Can you take? Oh, yes, you're all set now.
Yeah, I will start now. Can you all see the screen?
Yes.
Okay, firstly, I want to thank all the organizers for allowing me to be part of this wonderful meeting. What I want to do over the next 30 minutes is give you a background to neonatal diabetes. Firstly, I have nothing to declare in terms of conflict of interest. So what I will do is focus on giving you a background to what is neonatal diabetes mellitus. I'll briefly touch on transient neonatal diabetes mellitus. Most of my talk will be on the permanent forms of neonatal diabetes mellitus. I will review the molecular mechanism of some of the common forms of neonatal diabetes mellitus. I will show you how precision medicine has become extremely important in managing some forms of neonatal diabetes mellitus. I will show you some of the research that we've done in Qatar on neonatal diabetes mellitus. And finally, just touch on some of the ISPAE guidelines for some of the monogenic forms of diabetes, especially neonatal diabetes mellitus. So the definition so far is that neonatal diabetes mellitus is hyperglycemia, usually diagnosed within the first 6 months of life. And Shankar did a lovely presentation. Just remember, there are a few other causes of hyperglycemia, but this is persistent hyperglycemia, usually associated with low insulin levels and low C-peptide levels. Most patients are diagnosed within 6 months of life, but you may make the diagnosis occasionally later on in life. There are some adults that have been diagnosed with molecular basis of neonatal diabetes mellitus as well. Now, as I'll show you throughout the talk, the incidence of neonatal diabetes mellitus varies depending on which part of the world. As I show you in the region that I live, it's relatively common, whereas in other parts of the world, it's relatively uncommon. There are two main types, the transient form and the permanent form. Now, in terms of clinical and biochemical presentation, these children typically are born with intrauterine growth retardation, and this is because insulin is a growth factor, so they have very little insulin. They may present with failure to thrive, poor feeding, dehydration, typical of what Shankar presented, or with sepsis. And biochemically, they'll have hyperglycemia, low insulin, low C-peptide, may present acute acidosis, and typically they're autoantibody negative. Usually all 4 antibodies are typically negative in the first 6 months of life. Now just touching on the transient form. So this is typically hyperglycemia that develops within the first few weeks of life. And the typical presentation that I've already described may be present in these patients. But the interesting thing is that this form of diabetes usually goes away by the age of about 3 months. And what is interesting is these patients then are okay until around adolescence or early adulthood when they relapse. They get a different form of diabetes then. And typically what happens, if you look at the underlying sort of molecular mechanisms in terms of insulin secretion, they lose this first phase of regulated insulin secretion when they start relapsing. And the exact mechanisms that trigger the relapse and the exact mechanisms that bring on the relapse are unclear, but related to the inability of the pancreas to secrete insulin. And in terms of the genetic mechanisms, this slide will just show you that these are different from the permanent form. The most common mechanisms for the transient involve imprinting abnormalities. And these are the common mechanisms by which you get defects in imprinting. For example, you may get uniparental disomy for chromosome 6. You may get unbalanced paternal duplication of 6q24 and maternal methylation anomalies. And as I'll show you later, there are some forms due to KTP channel defects, which we'll go back to later. So just bear in mind the most common forms of transient neonatal diabetes are due to abnormalities in the expression of imprinted genes localized at chromosome 6q24. Now I'm going to focus mostly on the permanent forms and go through in more detail in all the different, the common forms of permanent neonatal diabetes. So again, the important thing here is that this never goes into remission. These children will always have the diabetes. The clinical presentation is very similar to the transient forms I've shown you, and none of these are due to abnormalities in 6q24. Now, the permanent forms of neonatal diabetes, until about 15 years ago, there's very little was known about the molecular mechanisms. And there's been a rapid explosion in knowledge in trying to understand the molecular basis of this diabetes. And at the moment in time, there are over 33 different molecular bases, molecular mechanisms or genetic mechanisms described which underlie permanent neonatal diabetes mellitus. So when I see a patient with this sort of diabetes, I have a very simple sort of classification in trying to understand what might be going on. I want to share my simple sort of thought process. So firstly, could this be due to an abnormality in the genetic mechanisms which regulate the developmental biology of the pancreas? In other words, is it due to the fact that the pancreas is present or hypoplastic? Is it due to syndromic form? And we had a lovely presentation from Shankar on one particular syndromic form. Could this be due to transcription factor defect? And I'm going to show you a few examples of transcription factor defects that lead to different forms of diabetes. Insulin gene mutations. Could it be due to defects in channels that regulate insulin secretion? And this is, we'll talk about this in more detail. This is where, for example, KTP channels or thymine regulating channels controlling insulin secretion. Or could it be defects in enzymes, for example, glucokinase, which is a very important enzyme involved in glucose physiology? Or is it a mixed etiology? So this is a very simple classification. When you see a patient with neonatal diabetes, this is the way I think of it, because as you'll see in the next table, there are so many different causes. So it's important to have a simple understanding of sort of classification, what might be going on. Now, I put this table up just to illustrate some of the different forms of genetic mechanisms of neonatal diabetes mellitus. Now, this table is not comprehensive. It's not up to date. There's always new diseases being described every few months. So in red here, I've listed the common genes that lead to abnormalities in the developmental biology of the pancreas. We're going to be focusing on the defects in the channel genes. The enzyme defect I discussed is glucokinase, and I'll touch briefly on some of the others as I go along during the talk. So this table just summarizes most of the common genetic mechanisms of permanent neonatal diabetes mellitus. So I just want to show you some typical examples of all of those before I go into the common, the channel gene, the channel causes of neonatal diabetes mellitus. So an example of a pancreatic hyperplasia abnormality is due to PDX1. Now you know that the pancreas develops from the lining of the gut And these two buds develop, the dorsal bud and the ventral bud. And they start expressing this transcription factor called PDX1. If PDX1 is absent, these buds do not form. So you get pancreatic hyperplasia. So an example of pancreatic hyperplasia are mutations in the transcription factor PDX1. And these are homozygous mutations, in other words, two mutations. As you know, a form of MODY is due to a single mutation in PDX1. So this was the earliest example of a pancreatic hyperplasia gene mutation described in 1997. Somebody in the chat asked a question on IPEX syndrome. So if you see a patient with neonatal diabetes mellitus who's got immune dysregulation, polyendocrinopathy, the typical features may be diabetes, chronic enteropathy, villus atrophy, skin abnormalities, autoimmune hemolytic anemia, neutropenia, thrombocytopenia. That should be alerting you to IPEX syndrome. Another, I think somebody asked this in the chat box, central hypothyroidism may be associated with GLIS mutations and polycystic kidney disease with neonatal diabetes mellitus. So again, there's very important clues there as a link with neonatal diabetes mellitus. And this syndrome was beautifully discussed from Dr. Schenker. Remember, sorry? Can you hear me? Can you hear me?
Yeah, go ahead, Dr. Khalid. I can hear you.
So this syndrome was described beautifully by Schenker, Volker-Allison syndrome, and I don't think I need to go into it in detail. Remember this little dysplasia, very, very important practical points were discussed. Make sure you do the X-ray as well. And make sure you look for other clinical manifestations of this condition. A few other ones, but this is a PTF1A mutation. Again, the link with this one is cerebellar hypoplasia. And if you see a patient with cerebellar hypoplasia and neonatal diabetes mellitus, you should think of PTF1A. Another one called neurogenin 3. This is a transcription factor. This is very important in developmental biology of the pancreas, as well as regulating the developmental biology of the epithelial cells in the gut. So these patients, this was one of the cases described by Oscar from Exeter. These children have severe diarrhea, and on this histology you can see there's an abnormality in the endocrine cells of the gut. So they have severe diarrhea as well as neonatal diabetes mellitus. And finally, another example of a transcription factor, NeoD1. This plays a very important role in the developmental biology of the pancreas as well as the brain. So homozygous mutations lead to cerebral hyperplasia, visual loss and hearing loss, as well as developmental delay. And these were the two families reported. The clinical features of the families are listed here. One family was from Pakistan, one was Hungary, small babies, severe hyperglycemia. The neurological features are listed here. So cerebral hyperplasia in both cases. Severe myopia in this one, retinal dystrophy, moderate hyperopia in this one. So severe developmental syndrome with NeoD1. So these were just examples of different transcription factors, developmental biology, and different syndromes that you might see in patients with neonatal diabetes mellitus. And this is just the MRI scan of these patients. They have cerebellar hyperplasia illustrated here. Now, I think Dr. Mohin touched on this. You can also get neonatal diabetes mellitus due to mutations in the insulin gene. So these are heterozygous mutations, also dominant, again, not associated with beta cell antibodies. And mutations occur the critical part of the pre-pro-insulin gene. And the mechanism involves abnormalities in folding and progression of pro-insulin to insulin in the secretory pathway. And these were the families that were described in 2007 by Joanne Stoy and a dominant sort of inheritance pattern. And this is just showing you the actual pre-pro insulin molecule with the mutations in certain sites as shown. Now, the most common cause of neonatal diabetes mellitus in the Western world is due to these KTP channel defects. These were the first papers published in 2004 and 2006. So the first paper described mutations in the KAL 6.2 gene, which is one of the components, which encodes for the component of the KTP channel. And the ABCC8 gene was described in 2006. Now, just for those of you that may not be familiar with what these channels are, so I'm just going to illustrate a cartoon model here just to show you what these channels do, because then you'll understand how the sulfonylureas actually work. So this is a simple outline of a pancreatic beta cell here. So glucose comes in, glucose gets metabolized, and glucose gets converted into these energy-rich molecules. And then these are the channels. So these channels sit at the surface here, and they're composed of the outer SUR1 here and the inner KR6.2 here. So when the ratio of ATP and ADP changes, these channels close and they cause depolarization of the membrane here of the beta cell. That allows the entry of calcium, and then you get insulin exocytosis coming through here. So you can see the channel plays a very, very important role in insulin secretion. And Dr. Mohan showed you a lovely slide where they also screen for congenital hyperinsulinism. So defects in this channel also lead to the opposite condition of severe hypoglycemia. And he's absolutely right when he says that the management of the patients with congenital hyperinsulinism is extremely complicated. So in neonatal diabetes, what the molecular mechanism here involves an abnormality in this channel, so the channel cannot close. The channel remains in an open state, and therefore you do not get depolarization of the membrane. So this is a very simple understanding of the molecular basis of these channel defects, how they lead to neonatal diabetes mellitus. Whereas if the channel is completely closed, you get the opposite condition of congenital hyperinsulinism. So you can see how this channel is fundamental in regulating insulin secretion. And these were the original patients described by Anna Gloin with the KCNJ11 mutations leading to permanent neonatal diabetes mellitus. And what they observed was, if you give these patients tobutamide, you get a lovely increase in insulin secretion compared to if you give them glucose. And this led to understanding the mechanism of how sulfonylureas might be working in these patients. And then in 2006, the ABCC8 gene mutations are described. And interestingly, if you look here, so some of these were transient. And that's why when I showed you the mechanisms of transient neonatal diabetes mellitus, some of the transient forms may also be due to ABCC8 mutation. So here's another family with transient form of neonatal diabetes mellitus due to ABCC8 gene mutation. Now, the mechanism of the disease, as I explained, this channel remains open, it doesn't close, it doesn't sense the changes in the concentration of the ATP that I showed you that's generated from glucose metabolism. And it was noticed that some of these patients, with especially the KCNJ11 mutations, had not just neonatal diabetes, but they also had development of delay, muscle weakness, and epilepsy, and they called this the DEN syndrome. So because they noticed that when they gave tobutamide, they got a very lovely response in terms of insulin. This led to the hypothesis that maybe some of these patients may respond to sulfonylureas. And then there was a long list of publications, so many publications from all over the world describing the response to neonatal, to sulfonylureas in those patients, not just with the KCNJ11, but the ABCC8 gene mutations as well. I've just listed some of these here. This is not a comprehensive list. This is just showing you some of the earlier case reports documenting the response to sulfonylureas. And you can see here, very lovely illustration of the improvement in the HbA1c with sulfonylurea. And this is just over time, even better improvement. So coming back to the molecular mechanism, so how might these sulfonylureas be actually working? If you go back to my simple cartoon model here, so remember that this channel is in an open state. It's not closing in patients with neonatal diabetes mellitus. So if you give a sulfonylurea, the sulfonylurea binds to the SUR1 component here and actually closes the channel. And if you close the channel, remember what I showed you, you get the depolarization, you get the calcium entry and the exocytosis. So this is the molecular mechanism of how the sulfonylurea actually works. It binds to the outer surface, the SUR1 component of the channel, and closes the channel to release insulin. So now when you give your patient sulfonylureas and you see an insulin response, this is what's happening at a molecular level. Now, this is the latest study looking at the follow-up of the vast majority of patients that were diagnosed early on in terms of long-term follow-up of glycemic and neurological outcome. And very reassuringly, these patients maintain good glycemic control over the long term without any serious adverse effects, despite being on high doses of sulfonylurea. There is debate whether the neurological symptoms improve some of these patients. Some case series say they do, in other case series say that the neurological symptoms don't really improve. And I think the debate is still out there, although my personal experience is that not all the symptoms improve, the neurological symptoms. There may be some improvement in some patients, but not all of them. But reassuringly, from the point of view of giving sulfonylureas, there's no long-term side effects documented so far. And one of the key features Dr. Mohan and Dr. Shankar touched on also is very, very important to make the early diagnosis so you can start sulfonylurea treatment as soon as possible. Now, one other condition, again, Dr. Mohan mentioned, very, very important to diagnose neonatal diabetes because you can make a difference to patient management. And this is another transporter defect I'm going to touch on briefly. So this is Rogers syndrome. Rogers syndrome is the association of diabetes mellitus, anemia, and deafness. One of the cardinal features is this thiamine responsive megaloblastic anemia. And this is due to homozygous mutations in this transporter SLC19A2. And as I'll show you in a minute, very important to make the diagnosis because of precision medicine. You can make a difference to the management of the patient by giving them thiamine. Now, this is the sort of molecular mechanisms. This is the thiamine transporter. This thing here is bringing thiamine into the cell. And thiamine has got lots of roles, especially regulating metabolism in different cells, especially in the beta cell, where it's used for insulin secretion. And this was the study which has documented the most number of patients and their follow-up in terms of response to sulfonylureas, in response to thiamine administration. So 32 individuals were followed up. The onset of the thiamine responsive megaloblastic anemia ranged from birth to 4 years. But from the diabetes point of view, from 6 weeks to 8 years. And diabetes was diagnosed first year of life in 15 individuals, and 9 of them sort of before the 6 months of age. So you can see not all of them were diagnosed within the first 6 months of life. That's why it's important to be aware that some of these disorders can present usually slightly older than 6 months of life. Now, this is very, very important slide because this is showing you the response to thiamine administration in these patients. So they had follow-up data for 15 individuals who were treated with thiamine. And they noticed that in 4 patients, they were able to stop insulin. So really, really, really incredible. And in 7 patients, the glycemic control was really good despite using low doses of insulin. But interestingly, not all the patients showed response. So this condition is important to diagnose. You may make a difference to some of these patients by giving them thiamine. And this is just showing you the clinical features. So the diabetes was the most common, deafness second, anemia, the megaloblastic anemia, the neurological features, some of the cardiac features, and short stature may also be part of the condition. And this is just showing you the improvement with thiamine in response to the HbA1c being better when they were treated with thiamine. Now, I came across this very interesting case report from your part of the world, where the authors didn't have access to oral thiamine, but they used a compound called bentothiamine, and this basically is a synthetic preparation of thiamine. And they noticed that once the patient had been on this for some time, actually the insulin requirement of the patient progressively reduced, and she was in remission for the last 2 years. And they confirmed the genetic diagnosis of this condition. So very, very interesting observation that even if you don't have thiamine, you may have the synthetic preparation here might actually work in some of these patients. And this is very important. I've shown you 2 different types of neonatal diabetes mellitus where you can make a complete difference to patient management. This is translational medicine. This is what precision medicine is all about. And I really like the words of Dr. Mohan Ray said, you must get a genetic diagnosis. It's really, really important because that will make your management completely different once you have a molecular diagnosis. Now, just a few slides just to show you that not all causes of neonatal diabetes are the same throughout the world. The etiology will depend on which part of the world you live in. For example, I live in Qatar in the Middle East. We do not see ABCC8 or KCNJ11 mutations. We have a completely different cause of neonatal diabetes mellitus. And that's really because of the high degree of consanguinity in this part of the world. Now, for example, the commonest cause of neonatal diabetes mellitus in Saudi Arabia is what Shankar already described, Mulcahy-Allison syndrome. Whereas where I used to live in the UK, the commonest cause is those channel mutations, the ABCC8 and the KCNJ11. Now, I did a brief look at the Indian experience, and I'm really privileged to see that there are so many publications coming out from India. And I noticed that you guys have a mixture. You have syndromes, you have channel mutations, you have really the whole experience of different types of neonatal diabetes mellitus. And given that India is such a big country, it's not surprising that you see a mixture of all different types of diabetes mellitus. These are just some of the publications I put up from the Indian colleagues. I'm sorry if I missed any of you out, but the aim of these publications was to show the spectrum of diabetes cases that you see, but not to illustrate every case report. And I apologize if I missed out anybody on these papers. So just for the last few minutes, just show you our findings at Qatar, what we've been doing here. So we've started working on this about 3 years ago. And we, as you know, Qatar has a very small population. The 2.6 million is the total population of our country here. But we have at the moment, this slide was prepared a year ago when I published the paper. Now there are 10 patients with neonatal diabetes mellitus. And I want to show you that the commonest cause of neonatal diabetes mellitus in our country is that PTF1A. If you remember, I showed you PTF1A causes neonatal diabetes mellitus due to pancreatic hyperplasia and cerebellar hyperplasia. We do have one Walcott-Rallison syndrome, and this patient of ours had severe liver disease, and I think this patient went to the UK and had the liver transplant. That's the latest that I have on that particular patient. So these patients can be very, very sick, as already described. So our patients, like I said, the most commonest cause was PTF1A, but we've seen enzyme, we've seen, for example, insulin gene, glucokinase, and HNF1 beta as another cause of neonatal diabetes mellitus. And I mentioned right at the beginning that the incidence varies in which part of the world you live in. So Saudi Arabia here has the highest incidence in the world. Qatar is second, followed by UAE and Oman. In Qatar, we're about roughly 1 in 23,000 by birth. That's our incidence of permanent neonatal diabetes mellitus. Now, just briefly touching on the ISPAE guidelines, this is important for all the junior doctors in the audience. These are the key take-home messages. Remember that monogenic diabetes accounts for 1 to 4% of all your pediatric cases. Any child you diagnose in the first 6 months of life, you must do immediate molecular genetic testing. And I'm so impressed that in India you have a center now. You're so lucky. You have a center which does free genetic testing for you. You should be really proud that this has been set up. And I've been trying to set up this here in the Middle East, and it's impossible. So I think you should be really, really proud of what you've achieved. Because type 1 diabetes is very rare in the first 6 months of life. Now, occasionally, these patients may present between 6 and 12 months. So if you have a patient with antibody negative diabetes between 6 and 12 months, you should also think of neonatal diabetes mellitus and maybe discuss with Dr. Mohan testing those patients as well, because they can turn out to have different forms of neonatal diabetes mellitus as well. And finally, I've already shown you that once you have a molecular diagnosis in your neonatal patients, this may guide you to management. If you have an ABCC8 or KCAJ11 mutation, give them sulfonylurea. The vast majority of patients will respond. There are 1 or 2 exceptions, but the vast majority will respond. Remember that the transient forms may go away, but these patients need to be followed up because they'll develop diabetes later on in life. Remember to look for other clinical features in patients with neonatal diabetes. I've just touched on some of the syndromes, for example, the intestine, the brain, the liver, the skeletal. So many different aspects may be involved in different types, depending on the molecular basis. And thank you very much. I hope I didn't go over time. Thank you for listening.
That was a fabulous talk, Dr. Hussain. You have covered almost all aspects of neonatal diabetes. I've never seen such a comprehensive presentation, and congratulations on your own series. You have the experience of working in both UK as well as in Qatar now. So it was fabulous. Dr. Shaila, shall take a couple of questions? I think there is something in the...
Yes, sir.
There are a few questions that can be taken.
Okay.
Yeah. So, okay. So Dr. Divya Lakshmi, what is your go on insulin regimen in neonatal diabetes? Rapid acting analogs or regular insulin? Or how do you dilute the insulin when the child is so small? So how do you treat them with insulin?
Very, very good questions. These are very practical questions, and these are really challenging questions. I mean, the doses of some of these patients I need are so tiny. I mean, there are lots of cases described where people have diluted insulin, and it does actually work. They need long-acting insulin, and they also need short-acting insulin. So there's no, I cannot give you like a protocol. There isn't a protocol developed for these patients who need insulin. It has to be individualized for each particular patient. People are using pumps around the world. Pumps tend to, if you can afford a pump, pumps might give you a better control. We've got 2 patients here that are on pump therapy, and we found that pumps are better than giving subcutaneous injections. But it may be because people can't afford them. It may not be available.
The dose is so small that it's
so
sometimes
tiny.
difficult to give it in a pump.
Absolutely. Absolutely. So tiny.
So there's another question from Dr. Santosh Oleti. Dr. Hussain, 14-year-old child with WRS and severe short stature and skeletal dysplasia having painful gait-limiting mobility. Can you share any experience such cases, any hip surgical intervention to improve mobility, reduce pain and quality of life?
We refer these patients to our orthopedic surgeons, but I don't think there's much they can do because this is a skeletal dysplasia. I'm not sure if they have any procedure that will benefit them. They may help with pain relief, but in terms of actual improving mobility, I think it's limited.
Also, the prognosis is so poor.
Prognosis is so
very
poor.
depressing.
Absolutely. Absolutely.
Yeah. So, Dr. Ahilya Ayavu, is there a difference in response to glimepiride or glibenclamide in PNDM due to potassium channel? You can also add glycoside to that. And I think you showed the work from Dr. Ewan Pearson, the original paper where glycoside was actually used in that Lancet paper.
Yes, absolutely. I think most of the sulfonylureas work as long as your dose is correct, and you may need to give high doses as well.
Yes.
Remember the papers I showed you, the follow-up data shows even high dose sulfonylureas, there's no long-term side effects at the moment.
That's
So if you're going to use high dose, just monitor the patient for a few days in hospital, but then after that, it's very safe, very, very safe.
Yeah. And and in fact, there are some reports where even DPP-4 inhibitors have been used, and they also may work. And you showed the other report. Okay, so Dr. Radha Venkateshan, our head of genomics, who does all our work. Thank you, Radha. In your Rogers syndrome series, is it because of the nature of mutations, some of them needed low-dose sulfonylureas?
The Rogers,
you mentioned that many of them responded to thiamine, but some of them didn't. So.
Yeah, so basically, because this series was from around the world, I don't think they had all the data on every patient. I think from the data that we have already, not everybody with Rogers syndrome responds to thiamine, even if you give high dose thiamine, not all of them. And what is interesting, we don't know why. It may well be mutation related. It may well be that there was diagnosed late. It may well be that there was a time lag. That is not clear at the moment, but every patient with Rogers, you should give them thiamine. Yes. I mean, if it was my patient, I would try it. There's no harm. There's no harm by giving thiamine.
Yeah, I think like we see in congenital hypoglycemia, different mutations, some of them respond to diazoxide, some of them respond to octreotide, some don't respond to both. Unless you have a large series, I don't think you'll be able to split them up into. And I think we'll take the last question and then stop from Dr. Ahila Ayavu. Dr. Khalid, does diabetes in your patients with PDX1 respond to gliptins?
I don't think so, because it's pancreatic hypoplasia.
You'll need insulin.
Because the pancreas is so tiny, it's just, there's no reserve there. So you cannot stimulate it. I've actually tried, when I was in London, I had a patient with PDX1. I tried a GLP-1 agonist to see if I can get the pancreas to grow. But after 6 weeks, nothing happened. So I stopped.
I think they'll need insulin, yeah.
Absolutely.
Okay, so I think this part of it has been very interesting. We have had fantastic talk on neonatal diabetes and the case presentation on Walcott-Rollison syndrome. I think it's a treasure of clinical material that we have heard from all around the world, from India and from Qatar and from UK. I've learned a lot from this session. So over to Dr. Shaila and Divya.
Thank you very much, sir. Both of you were very excellent, very interactive session. Thank you, Dr. Hussain and Dr. Mohan. So now we can move to the next session. Nirav, next slide, please. So the second hour will be for the diabetes. And for this, we have Dr. Payal from Department of Pediatric Endocrinology, Indira Gandhi Institute of Child Health, Bangalore. The mentors are Dr. Vani and Dr. Raghupati, sir. To discuss this case, we have Dr. Tushar Godbole.
Slide.
Yeah, we have Dr. Tushar, who is a pediatric and adolescent endocrinologist, director, Harmony Health Hub, Nasik, and he is also Associate Professor, Dr. Vasantrao Pawar Medical College and Hospital, Nashik, Visiting Consultant, Aurangabad and Dhule. He has written book chapters in Guy's Textbook of Pediatrics, IAP Textbook of Endocrinology, and PG Textbook of Pediatrics. He has 4 national and 5 international publications for his credit. He's been executive board member of ISPAE in 2015, 16 and 19-20. Editor Maha IAP Bulletin 15 and 16. He has received Sarla Vaishnava Award for Best Research Paper in Metabolic Diseases, IAP Delhi 2010. Over to you, Dr. Tushar and Dr. Payal.
Dr. Senthil has also joined.
Has he joined? Just now. Welcome, Dr. Senthil.
Welcome all, and good evening to this scientific session. The later part, the first part, we just listened to neonatal diabetes, an interesting case and overview on the neonatal diabetes. Now we are moving on to the second part, that is obesity, and to present one common yet important case, especially in the post-lockdown and post-COVID. Have Dr. Payal Kubsad. So I'll request Dr. Payal to present her case.
Yes, sir. I'll just share my screen, sir. Is my screen visible, sir?
Yes, you could go on full screen mode.
Yes, sir. Good evening to one and all present here. I will be presenting a case of an obese adolescent. Miss D, 13 years, 8-month-old, presented with complaints of increased weight gain noticed since 1 year. Irregular menstrual cycle since the last 6 months. Mother gives a history of increased junk food consumption associated with weight gain of approximately 10 kgs in the last 1 year, with increased screen time of approximately 6 hours per day, with decreased participation in sports or games, and she used to spend most of her time at home in sedentary activities like watching TV and use of mobile phones. She attained menarche 1 year ago, menstrual cycle once in 2 months for 3 to 4 days, not associated with excessive bleeding. Complaints of acne over the face since the last 6 months. No history of cold intolerance, constipation or lethargy, pain abdomen or any voice change. No history of headache, blurring of vision, polyuria or polydipsia. No history of any drug intake. No history of snoring. No history of pain in the hip while walking. Birth history being normal. The birth weight was 3 kgs. Family history, no history of similar complaints in the family. No history of obesity, diabetes or dyslipidemia. No history of sudden death in the family. But father was diagnosed hypertensive 2 years ago. The height and weight of father and mother are as follows, with BMI being 26 and 25 of the father and mother respectively. Coming to the developmental history, developmentally normal with average scholastic performance. The diet history of this child was total consumption of around 3,100 kilocalories and 300 grams of proteins, with increased junk food consumption and intake of lots of sweets. Consumption of oily food from outside was consumed once in 2 days. Sweetened beverages like Coke and 1 to 2 packets of cream biscuits are consumed on daily basis. Constant munching of food every day, with non-veg food weekly twice. Coming to the general physical examination, vitals were normal, with BP 110/70 being normal. Acanthosis nigricans in the axilla and the neck, grade 4. Grade 2 acne was present, with no goiter, no increased facial hair, SMR pubertal, with a complexion similar to her father. Coming to the anthropometry of this child, her weight was 84.5 kgs. with height 159.6 centimeter and BMI of 33.4 kg per meter square. Her weight was above the 97th centile, height being more than 75th centile and BMI being more than 27th adult equivalent BMI. Her waist circumference was 90 centimeter, which is above the 90th percentile. Coming to what is childhood obesity? Obesity among children, adolescents, and even in the adults have emerged as one of the most serious public health concerns now, especially after the lockdown. Childhood obesity is a condition where excessive body fat negatively affects the child health and the well-being. And we have different definitions for childhood obesity by WHO, IOTF, and IAP, where obese and overweight is described as BMI more than 2 standard deviation and more than 1 standard deviation above the growth reference median, respectively. A child less than 5 years of age is obese if the weight for height is more than 3 standard deviation above the WHO growth standards. According to the IOTF guidelines, international BMI cutoff points are provided by age and sex for the overweight and obesity for the children aged 2 to 18 years, and they correspond to an adult BMI of 25 and 30 for overweight and obesity, respectively. For Indian population, we use the IAP charts and IAP guidelines, which says BMI cutoff points by age and sex for overweight and obese children aged 2 to 18 years corresponding to adult BMI of 23 and 27 respectively. Coming back to our case, acanthosis grade 4 in the neck and the axilla, as the acanthosis nigricans extend anteriorly and visible from the front, with severe acanthosis in the axilla visible from the front or the back. Coming to the grading of acne, grade 2, which includes the papules, comedones, and a few pustules. Coming to the investigations, her HbA1c was found to be 5.9 with deranged or altered lipid profile with elevated triglycerides and a low HDL cholesterol. Coming to the oral glucose tolerance test, HOMA-IR was found to be 14.18 and quickie index of 0.26. HOMA-IR is calculated using the formula fasting insulin into glucose divided by 405. Quickie index is calculated by 1 divided by log of insulin plus log of glucose, which explains us the insulin resistance in this child. Coming to the next investigation, ultrasound abdomen and the pelvis, which showed both ovaries with multiple small follicles of 6 to 8 cc, which is suggestive of bulky ovaries. Coming to the summary of the case, a 13-year, 8-month-old female with complaints of increased weight gain since 1 year, irregular menstrual cycle and acne over the face since the last 6 months with increased high-calorie and junk food consumption and sedentary lifestyle. On examination, she was found to be obese with waist circumference of more than 90th centile and severe acanthosis nigricans of grade 4. Investigation done showed altered lipid profile with pre-diabetic range of HbA1c with elevated HOMA-IR suggestive of severe insulin resistance. So a diagnosis of exogenous obesity with metabolic syndrome was made. Now, what is metabolic syndrome? Abdominal obesity, where the waist circumference is more than the 90th percentile according to the age and sex, with 2 or more of the following: high fasting blood glucose, high blood pressure, hypertriglyceridemia, and low HDL cholesterol. Our case has 2 of the above complaints of high triglyceridemia and low HDL cholesterol. Coming to the management of this style, we advised her for a lifestyle modification, which includes decrease in the non-academic screen time to less than 2 hours a day, to participate in the physical activity, exercise, or sports for at least 60 minutes a day. Diet modification was advised. Tab metformin 500 mg BD was started initially. Coming to the treatment of obesity includes non-pharmacological and non-pharmacological treatment. Non-pharmacological includes healthy eating, which includes the 5-2-1-0 rule, where 5 fruits or vegetables has to be consumed on a daily basis, with physical activity of at least 1 hour per day, to limit screen time to less than 2 hours for the non-academic session, and adequate sleep, with 0 sweetened or sugar items to be eaten. Coming to the medical treatment or pharmacological treatment, there are a few FDA-approved drugs in children, which includes orlistat and metformin, which is used in more than 10 years for children with type 2 diabetes mellitus. And the recently approved FDA-approved drug for children more than 10 years is GLP-1 analogs, which is also used for children with type 2 diabetes. Thank you.
Thank you, Dr. Payal, for that case. We have a session coming up dedicatedly on pediatric obesity, but then we can have a few questions particularly on this case, not obesity in general, but so I have a few questions or comments for you. So you mentioned that the list of approved drugs, you mentioned that orlistat is one of the approved drug for pediatric obesity, and in your case you have given metformin. I understand that the HbA1c was 5.9 and she had frank acanthosis. So what made the choice of medical therapy as metformin and not orlistat in your case?
So since she was in a pre-diabetic range, and metformin is started for obesity with type 2 diabetes mellitus, we have started on metformin.
You had asked for that pain in the hip joint. So was it related to what was your thought process behind that?
Sir, we asked for the complications of obesity, sir, since her BMI was 33.4, and we had, in view of complications, which is the skipped capital epiphysis. So I had asked for any pain in the hip joint or pain while walking, sir.
Great. So in metabolic syndrome, you correctly mentioned that the girl has metabolic syndrome, and you sensitize the, all the trainees that are attending that, not just the obesity, but we should also look at the, adjoining, contributing factors. But is the definition, holds true for, all children, or do we restrict it to just, children above 10 years?
Sir, there are children above 10 years.
Above
10 to 16 years and more than 16 years.
Correct. Thank you. I think that was, although it was a very common case, I'm sure everybody is seeing such cases nowadays in our OPD. A few comments that I wanted to make, that you had that TSH value that was 7. Although you mentioned it and you did not comment on it, but I'm happy that that case was not treated with levothyroxine, and all of us now know that TSHs ranging in that 5 to 7.5 or 8, they're better left alone, provided you have ruled out any goiter or any family history for diabetes. Regarding screen time, you said that the patient has a lot of screen time. So where do you see in the AAP recommendation, they mentioned that 2 hours is the non-academic screen time for children above 2 years. But in Indian scenario, I think our children, many of them do go for the tuitions, and tuition is also one sitting idle time. So I think we should also cut down their screen time, not just blindly going by the AAP recommendations, but we should individualize our own recommendations. There was one comment from my side, and I'm sure Dr. Senthil would also like to add and elaborate more on that. But then this insulin HOMA-IR index, in your case, you have done fasting insulin level and calculated that HOMA-IR index. But I guess the recommendations are against doing fasting insulin levels for clinical purposes, because in adolescents, the values of insulin in normal adolescents versus the pre-diabetic children, or children with metabolic syndrome, there is a lot of overlap. So I think the general message, although you mentioned that the HOMA-IR was elevated and it's a part of the disease, insulin resistance, of course, but then I would recommend not to test insulin, fasting insulin in every child with obesity. That should be the message. Dr. Senthil, would you like to comment on that, or you will be touching upon in your talk?
Yeah, I got that in my list.
Okay, fine. So we'll not spend more time on that. I think that was a wonderful talk. And
there are questions in chat box. I think Shaila ma'am.
Yeah. Absolutely correct. Dr. Santosh and Dr. Shaila, both of them have raised questions. Firstly, Dr. Santosh has mentioned, which actually struck my mind as well, that have you tried lifestyle intervention for at least 3 to 6 months before initiating the drug therapy?
Yes, sir, but there was no improvement in her. I mean, there was weight gain only, sir. There was no reduction in the weight. So we had started on the pharmacological treatments.
Okay. And Dr. Shaila ma'am has asked, was the ultrasound performed to document any, steatohepatitis or any fatty liver?
No. I asked why was ultrasound done?
Okay, sorry. I got the question wrong.
I'm
so
sure
why was the
she has done it for PCOD,
Yes.
but I think adolescent PCO ultrasound is not one of the criteria.
Yes, ma'am, I agree, ma'am. Within 1 year.
Yeah. So I think we have 10 minutes in hand, but let us utilize those while listening to Dr. Senthil, because it's a very, very important talk, and it gives me a pleasure introducing the speaker for the obesity session. We have Dr. Senthil Seniappan, who is the Clinical Director for Endocrinology and Associate Professor at Alderhay Children's Hospital, Liverpool, UK. He has been trained in endocrinology at the Great Ormond Street Hospital, London. He is the clinical lead for CEW Weight Management Clinic at Liverpool. He is the recipient of several grants and several awards, including the prestigious UK's BSPAD Research Award and the US Endocrine Society Award. He is the convener of the ISPAE Connect webinar, the POC chair at BSPED, that's the British Society. He is the secretary for the ISPAE Clinical Fellowship Committee, and he has more than 70 publications in various peer-reviewed journals, including the NEJM, and he has authored many publications. And this is, I'm sure this is the shorter version of his CV. The CV is actually very elaborate. And we have Dr. Senthil deliberating on the important topic, that is obesity, causes, consequences, and the interventions. So over to you, Dr. Senthil.
Thank you very much, Krishna, for that very kind introduction. And thank you, Divya, Dr. Shaila, and Hari for the kind invitation to talk on obesity today. It's my pleasure to join you all, and great to see all the discussions and the interactions. So I know obesity is a very broad topic, so I'll try my best to give an overview over a few minutes, and then we can have some discussions and Q&A after that. Hope my slides are visible clearly.
Yes.
So as we all know, thank you. So as we all know, it's obviously overweight and obesity is a massive problem across the globe. Now it's a big issue. There are parts of the world where like 27 to 40% of children are either in the overweight category or obesity category. So it's a big problem, and we as endocrinologists, we face this, and we have to deal with this wherever we work across the world. As Paul mentioned, there are different cutoffs. The one we use in UK, based on the UK BMI charts, weight more than 90 percentile we categorize as overweight, and more than 98 as obesity. And it's important we use like ethnic specific charts to categorize overweight or obesity. I'm sure you all know the number of complications related to obesity. I don't probably have to go through, but I'll just share some patients we have seen in our practice. So this is a patient, 13-year-old referred to us from the respiratory team. As you can see, the weight has been escalating over many years, despite all sort of interventions. And at 13, she was having severe sleep apnea and needed overnight CPAP to manage that. This is another patient who was referred to us again from the liver team at the age of 13 years, significant weight gain, had a rearranged liver function, had a liver biopsy, which confirmed hepatic fibrosis, which is the next stage of the fatty liver. And fortunately, she engaged in the lifestyle intervention and she managed to lose some weight, and the liver function, everything actually normalized. Again, goes on to show that if you achieve some weight loss, these complications could be reversed. Okay, this is a patient with again, 15 years, referred to us with headaches and subsequently noted to have severe intracranial hypertension. Now, as we all know, this is a rare complication, but it's quite an unrecognized, less recognized complication. And some patients alarmingly can be asymptomatic as well. So unless we do, detailed ophthalmology examination and then look for, we may miss the intracranial hypertension. And some of them can be quite challenging to manage. This patient needed a number of like lumbar puncture to relieve the pressure from the brain before symptoms settle, was also on acetazolamide and other treatment. Subsequently managed to lose some weight and all the symptoms improved, came off the treatment for the intracranial hypertension and did well afterwards. This is a different patient, a 13-year-old referred to us. As you can see, the weight has actually been escalating so rapidly in the last 2 to 3 years, has gained like 50 kilos, and the current weight is around 187 kilo. This is somebody who I've seen with the maximum weight I've seen in my sort of practice. Has got a heterozygous MC4R mutation, so it's not even fully sure that. Probably that's partly contributing to the weight, but there's also the other familial factors contributing as well. He has got an autistic spectrum disorder, so it's quite challenging to manage. And when we try to admit him for doing some investigations and starting treatment, only we realized as a children's hospital how much, this is going to be a problem moving forward for all of us, that our standard hospital beds may not be sufficient to admit some of these patients. So we had to hire a bariatric bed and make special arrangements in the toilets and other facilities before we could get him to the hospital. And because mother was also having obesity, so we had to make provision for mother as well to stay with him. So a different patient was 16-year-old diagnosed with type 2 diabetes mellitus, which was poorly controlled. As you can see, HbA1c is 120. Has also got other comorbidities like severe dyslipidemia, is on antidepressants, was on metformin and insulin, but wasn't taking really the insulin quite regularly. So the diabetes was always uncontrolled. Tried GLP-1 analogs daily, Victoza, without much effect. So just recently been started on the weekly semaglutide. So early days, but the blood sugar is now trying to sort of is settling into the sort of upper normal range now. And as you can see, the weight is coming down, but we're not entirely sure how much of that's due to the treatment or whether because of the poorly controlled diabetes, she's probably having severe glycosuria and probably losing some weight because of that as well, I presume. So I just gave some cases to showcase the severe complications we may come across in our practice. And just thinking what is our role as endocrinologists here is to identify any underlying cause or reason for obesity. And number 2, to manage the complications related to obesity. And number 3, then if you can, then achieve some weight loss as well to mitigate some of those complications. As we all know, the causes are foreign and few anyway, and that could include endocrine or genetic causes. Endocrine includes Cushing syndrome, hypothyroidism, growth hormone deficiency, and pseudohypoparathyroid. Syndromic, if they have dysmorphic features, developmental issues, or hearing or visual problems or hypogonadism, then we start thinking about syndromic conditions like Prader-Willi or Bardet-Biedl or Alström's, and monogenic causes where there is severe early onset obesity. And we as endocrinologists obviously come across Prader-Willi quite a lot. This is the commonest genetic syndrome associated with obesity in children. This is a patient I look after who was referred initially with hypothyroid, which developed at around 10 months of age. and also noted to have calcifications like subcutaneous nodules, and subsequently noted to have hypocalcemia and PTH resistance. And for the genetics, confirmed GNAS1 mutation confirming pseudohypoparathyroidism type 1. And then he continued to gain weight quite significantly of late and has got the complications related to obesity. So this is quite a rare condition, but when we are looking after managing children with obesity, need to think about these rare conditions, and doing a bone profile and PTH might help. Monogenic obesity is being recognized more and more of late, and we do now gene panels to identify this. Generally, children, the family history or early onset obesity, rapid onset obesity, and other features like red hair, which could be part of POMC deficiency or hypogonadism, and those other features could point towards looking for specific monogenic cause, which could be like leptin deficiency, leptin receptor deficiency, POMC or MC4R. There are some treatments becoming available, so it's worth thinking about these monogenic causes. And again, this is a patient in my service, as you can see, has had a normal weight until like 3 years of age, but subsequently started gaining weight quite rapidly. Has also been associated with behavior problems starting off at the same time, hyperphagia, and some autonomic disturbances. So he then subsequently has been diagnosed to have the Rohat syndrome, which is the rapid onset obesity, autonomic dysfunction, hypothalamic dysfunction syndrome. Now, this is more of a clinical diagnosis. There is no genetic cause identified as yet. And there is also a theory whether this could be more of an autoimmune problem rather than a genetic problem. So when do we actually investigate for or investigate patients presenting to us with weight management issues? So if the weight is more than 98th centile, and if there are features of any underlying cause or pathology, if there is features suggestive of obesity-related complications, or if there is a family history, then we do undertake investigations in those patients. And obviously, we want to do a detailed examination, like Pyle presented in the case, looking for acanthosis, papilledema, features of polycystic ovaries, dysmorphic features, and Cushingoid features will be important. Baseline investigation. So this is what I do. So I do fasting insulin and C-peptide as part of the evaluation. But as Tushar was saying earlier, probably it may not be needed. But the reason I do is like if you identify any impaired fasting glucose, then it helps to understand whether they are in the insulin resistance type 2 category. Oral glucose tolerance also is undertaken in some of these patients. Now, further investigations depends on the clinical features. If obviously you're suspecting Cushing's, then you would be doing dexamethasone suppression or urine-free cortisol. PCOS, then further investigations along those lines. If there are features suggestive of sleep apnea, then sleep studies may be indicated. Sleep studies are always tricky in these patients because if they have poor sleep or poor quality of sleep, then sleep studies may not be easy to undertake, may not be meaningful to interpret. So we now started using more like a sleep questionnaire, and based on that, then we select patients for sleep study subsequently. And if you're suspecting monogenic causes, then a gene panel will be useful after we have done the baseline microarray and FISH for probability. Again, depending on further comorbidities, if the blood pressure is elevated, then you would do a 24-hour blood pressure monitoring and consider treatment. Dyslipidemia may warrant treatment. And fatty liver, again, if the liver function is deranged, then an ultrasound will be useful. And we generally, if the liver function are more than 3 times the upper limit of normal, then we get our hepatologist involved at that stage. Moving on to the management, as we discussed before, obviously the key is lifestyle management, which is easier said than done. We all know that it's not straightforward, but those are the general sort of starting point or recommendations to aim for energy restriction by making dietary changes, increasing energy expenditure by improving the activity levels, and then modifying the behavior in relation to both. So what's our actual goals? Now, obviously, we all want to achieve some weight loss, and that's the key, which is going to reverse the complications. And that will be our first step, and which may be quite challenging in children who are growing. To achieve weight loss may be quite difficult. Sometimes even if we achieve like a weight maintenance, if they've been gaining like 15, 20 kilos in the last year or so, And then if you stop them from gaining any more, that by itself could be an achievement, actually. So, we may not necessarily always see a weight loss. But in the adult studies, there's a direct study from Newcastle which showed that if you lose like 15 kilos weight, then that would reverse most of the complications. So there is obviously merit in aiming for weight loss in relation to obesity, but the biggest problem is maintaining maintaining that weight loss or achieving what has been lost so far. That's always the issue, because rebound weight gain is quite common, and helping the patients to maintain that weight in the long run, or maintain that normal weight in the long run, is the key. And what we are trying to achieve by that is to reverse some of those complications and to make some meaningful impact to their health. So dietary modification, the general advice obviously is, using small portions, reducing the carbohydrate and increasing the protein salad content in the diet. If possible, aiming for an energy deficit of around 500 calories. Using the weight loss plates, so with a clear sort of direction of aiming for filling the plate with like vegetables or salad, half, and then remaining half with carbs and protein. Helping patients with certain recipes to cook favorite low carb, low calorie meals, and enabling them to read the labels in the foods, look for calories will be useful. And now, in terms of low calorie or low energy diet, that is not something we now advocate in children or adolescents, but probably might come in the future. There are some studies starting, and there are some Australian studies, and there are other groups starting studies as well. When we say low calorie diet, that's aiming for like 1500 calories in a day. And very low calorie diet is like 800 calories a day. And these are quite restrictive diets, and they have to be nutritionally balanced. And in growing children, if they're going through puberty, it may not be ideal to sort of restrict that. Even aiming for a normal calorie intake for whatever is recommended for the age should be sufficient to achieve weight loss in most patients. And there's a general tendency to underestimate calories in the food. That's for all of us, not just for the patients. I've just put some food items there. They're all the same weight, but they have different calorie content. So the muffins or croissants will be like 300 to 400 calories, whereas an apple will be around 50 calories. So that's quite important to understand that, and a food diary as part of the evaluation when we see them in the clinic will be useful. These are some of the dietary resources which could be shared with the families. Moving on to the physical activity, it's about increasing the activity, and there are a number of recommendations. And as we just talked about the screen time, you can have all these recommendations. How much are we able to implement? How much patients or the families are able to implement is what we need to focus on. So the general recommendation is, aiming for 60 minutes at least 3 times a week. And there are a number of benefits to improving activity, not just weight loss, but also for other reasons, improving mental health and other reasons as well. And the general difficulty might be finding the time in the day to do the activity or dedicated exercise, and that may always be the issue. We have started running virtual exercise sessions for our patients, like group sessions or also individual sessions through our teams, and that has been quite successful. So that's something could be implemented for the families if they're finding it difficult to go out to do some exercise or go to gym and things like that. Now, understanding the psychological factors, what drives the weight gain or what is maintaining the weight at the higher stage, that will be crucial. It's not probably as simple as we think. It's like just overeating and less exercise. It may be much more complicated than that. So those biopsychosocial factors, mental health issues, depression, is it comfort eating, is the family circumstance, is it obesogenic environment in the family, financial issues. This could be so many other reasons which are driving the weight gain, and unless we understand that and support that, it might be difficult just to focus on the weight and just to focus on the child, and sometimes maybe the whole family who have to participate in the program. So this should be unraveled. So eating or comfort eating, emotional eating could be just a coping strategy, and if by taking that away from them, we may not be helping them, might make their mood even worse. So giving support to come up with alternate coping strategies, and those things will be quite important. Understanding the family patterns of eating, and self-esteem and environmental social factors will be important. So when we deal with the patients, it may be very easy to take a very pragmatic approach and giving advice, telling people what to do, but that may not do the trick. Sometimes we need to suit or adjust our advice based on the patient situation. We'll probably have to take a very sensitive approach, especially when talking about diet. There could be very defensive attitude towards diet. So to get the real picture, sometimes we have to be a little bit sensitive when talking about that, and inducing a defensive behavior can happen very easily. And there's a big stigma around seeking help for weight management. So the patients that are coming to us asking for help, that's a very important first step they have taken. And it's very important that we then support them and take them through the journey rather than putting them off. We also use screening questionnaires to understand the mood and the behavior as part of our first evaluation. And when we are discussing behavior change, obviously these conversations will be time consuming. They cannot be done in a very quick consultation. Maybe we have to do like twice or thrice to meet the family, to understand them, to have some of these conversations, to make some meaningful change and help them to implement those changes. And there are a number of different techniques. I mean, obviously our psychologists will be using some of this, but we can adopt some of that in our practice as well. And the key is about using techniques like motivational interviewing techniques, using scales of importance and confidence, and also coming with more realistic goals. And nothing is going to change overnight. It will be time consuming, but coming with some specific measurable goals with one or two things that can change at a time. These solutions coming from the patients, it will probably be very easy for us to tell what they should be doing. And most people do know what they should do. It's just simply they can't do that for very many reasons. And we all have had that experience ourselves in our own life. So it's just about understanding that and maybe helping them to come up with a couple of things they can change, which they could do in the current sort of circumstance in their life. And then working on that will be important. And I found this useful to at least understand where our patients stand, and these stages of change helps to see, like, patients may be in different stages here. So you can start from the pre-contemplation phase. Somebody might be in that phase where they're not even thinking this is an issue, it is an issue, or any complication is an issue. Or somebody might be just contemplating about making some change. So then we can probably push them a little bit further to move into the next stage. Somebody might be in the preparation phase where they now decided to make some change and started working on it, but trying to find out what is it they could do. And that's where our advice there could help in that situation. Some might be actually putting that into action, taking efforts to make a change. Then we can just encourage them to continue that. And some would have reached a maintenance phase. Again, that's brilliant. Then we can help them to continue and make sure there is no rebound or relapse. And it's not unusual for these weight issues to relapse. So then if people have moved on to that phase of relapse, then again, that's not a big negative factor. It's just reassuring them and helping them to come back to the stage of going back into action phase and getting into maintenance phase will be important. So just understanding not all patients will be different phases, and a single advice will not suit all of them. So once we understand where they are, then we can fine tune our advice based on that. Moving on, now medications, we discussed some of this previously, as mentioned during the case presentation. Metformin is something which is not approved for weight loss. It's for type 2 diabetes more than 10 years of age. Having said that, we do prescribe for patients with weight management if lifestyle doesn't work. Whether they manage to continue the long-term question, the studies have shown a modest benefit if people are able to continue that. But due to the GI side effects, most people end up stopping them after a few months. Orlistat is approved, and it's not something we use quite a lot in our practice because, again, the GI side effects and issues when they're going to school, if they have tummy problems, have to go to toilet frequently, it becomes an issue. I haven't seen many patients being able to continue that. So at least in the UK, it's not something which is used very commonly. Bariatric surgery is very limited for certain group of patients who have failed all other measures, but the practice is different across the globe. There may be some parts of the world that are much more aggressive in going ahead with the surgery early on, and some parts of the world where this is only a last option and everything else has been exhausted. It's been shown to have benefit in adolescents in reversing the complications and the number of different procedures which are undertaken. And looking at it, the evidence for, like, we talk about lifestyle modification, but how much change are we able to achieve by that? So it's quite modest in terms of the weight loss, whereas bariatric surgery will be the extreme and might achieve quite significant weight loss. And there is a gap in between to bridge that in terms of treatment options. So incretin system has been focused a lot in the last few years, and liraglutide has come into use for weight loss in addition to obesity. And the SCALE teen study was the main RCT which was undertaken to look at the benefits of liraglutide, and which was shown over 56 weeks that it does help to lose weight compared to the placebo. And we did see in our practice, and we published that as well. What's interesting is if they stop the treatment, then the weight tends to bounce back. And this is the study for the effect of liraglutide, which is shown to be effective in type 2 diabetes mellitus for adolescents. Setmelanotide is coming now into use, and it's been approved for certain genetic conditions like POMC, PCSK1, and LEPR deficiency. It's quite an expensive drug, but it could help for those patients with that specific monogenic cause for obesity. So just listed some, just to summarize again, like we saw before, the approved medications for obesity, orlistat more than 12, liraglutide more than 12 years, and setmelanotide. For type 2, metformin, liraglutide, and exenatide. And in adults, semaglutide weekly subcutaneous injection has been approved for both diabetes and weight loss. So this might something which get approved or licensed for adolescents in due course. There's a study which is about to finish now. And oral semaglutide has been approved for diabetes in adults. The potential new therapies, as I said, semaglutide for adolescents. Diazoxide has been studied in Prader-Willi. The results are still not out. Topiramate has been historically used for other reasons, and we collected some data on patients, neurology patients who are on topiramate and who have also weight management issues. They have seen significant weight loss in those patients. Topiramate does have other side effects, so we got to be careful. And at the moment, it's not something used as a medicine just for weight loss. You might have seen the recent publications about the GLP, GLP-1 receptor agonist in the NEJM. So in adults, it's been shown to be quite effective, like up to 22% weight loss in adults for obesity. So that might be another option coming up in the future. And the others are all more experimental drugs like antibodies to activin 2 receptor, which is involved in hypothalamic regulation, and weekly long-acting amylin analog, or in combination with semaglutide. These are something at a very early stage which might become available for the future. I'm not saying drug therapy is something which is for every single patient. Of course, we have to start with lifestyle. Those are important for long term. But for some patients where we can't really make much change, and if there are a lot of complications, then we may have to use some drug therapy to push them to achieve some weight loss, which gives some confidence then for them to move on and make the other changes. So tackling obesity, it needs a number of people to work together. Now, long-term, as a community, we have to think about working with our primary, secondary care colleagues at all sort of levels in the community to work together to prevent obesity in the long term. So we will be focusing on individual treatment for the patients we see in our practice or clinic, working as part of an MDT. But working at the community level, making changes in the food environment or the activity environment in the community will be important to prevent this in the long run. And that's where the political and the geopolitical forces have to align to make work together. And we as clinicians probably have to push those things to happen. And this is our MDT. So we in UK, the last couple of years, the Q clinics, which is the complications from excessive weight clinics, have been rolled out in many centers, which has been centrally funded from NHS England. And this is some members of the MDT there. So we have like a dietitian, psychologist, physiotherapist, social worker, and a specialist nurse who deals with all the medical treatments. So we work as a team to identify the factors driving obesity in each patient, understand their circumstances, and fine-tune our support for them. This is some of the research we are undertaking in Liverpool in collaboration with the universities and LFC Foundation. We are running some programs in the community as well. PD loop studies to understand the pre-diabetes in a much better way. Motivate all the guys to use sort of guided activity using gadgets, see how we can improve the activity levels in young people with obesity. And we are also working with our innovation team to come up with a platform or a dashboard to collect the parameters. Like self-monitoring is important. Like if you think about diabetes, for example, we do monitor a number of things, including blood glucose and other stuff, which happens at home every single day. Whereas when it comes to weight management, we are not able to monitor much apart from the weight when they come to clinic, but we don't know what's happening on a day-to-day basis in terms of calorie intake, activity levels, the mood, the sleep, all those things. So I think self-monitoring here is key, and we are at early stage of developing all of this. Hopefully in the future, we can come up with some solutions to develop some apps and dashboards to capture that, so we can then again fine-tune our advice for these patients. So thank you very much, and I'm happy to take any questions. Thank you.
Thank you, Dr. Senthil, for that lovely presentation. Actually, it was a bird's eye view on all the aspects of management of obesity. I'm sure there are many questions in the chat box, but I have listed a few. Meanwhile, Hari and Devalakshmi can help me out. So there's one question by Dr. Lokesh. You have, I think, already mentioned that around 400 to 500 calories of weight deficit you mentioned in one of your slides. So how do you go about it? I mean, how do you calculate that weight deficit for that individual patient?
Sure. And that's where getting an understanding of what they are consuming in a week, for example. And when you ask for a food diary, or the reporting may not be accurate, and there may be tendency to underestimate. So getting a honest insight into what they consume in a week will be important. And with our dietitians, obviously when we look at it, you would, as we saw in the patient you discussed earlier as well, it will be way beyond what is recommended on a daily basis. Now, can't think anyone requiring more than 2,000 calories in a day. So, but usually it will be more than that. So even if you achieve what they're supposed to, or if you recommend what they're supposed to take, as a recommended intake, that should be sufficient. We don't have to go for any calorie restriction in most patients. Now, if you want to do a calorie restricted diet, then 1,500 calories is something to aim for. And you will be obviously looking at what they consume at different points in time. It's the snacks or per meal, and then we can give specific advice based on that.
So one related question that I want to ask is, the rapidity with which the weight comes down, is it also the factor that that predicts the relapse? I mean, if you lose the weight too rapidly.
Absolutely. I'm sure we all will agree that.
What speed of weight loss would you recommend for adolescents, especially teenagers? What should be the ideal weight loss?
So 0.5 kilo per week is what is generally recommended. 0.5 kilo to maybe 1 kilo, but half a kg per week is generally recommended speed of weight loss. You're absolutely right. Rapid weight loss, anything faster than that. We had patients then who are relapsed. It's not just a relapse. One patient lost quite a lot of weight, we were all quite happy and we are praising her, but actually her mental health was going down and down because she felt very pressurized by the family to lose weight. So, and she went into depression. I didn't know that, and she was self-harming. And then eventually our psychologist managed to identify all that. So we might inadvertently push some of these patients into eating disorder, and their relationship with the food might change in the long term. So we have to be quite careful in pushing some of this as well.
I'm sure many of us have had these cases where pre-lockdown we have achieved some 10 kilos, 12 kilos of weight loss, and during COVID they have regained that weight and maybe a 5 or 10 kilos above that. Dr. Jhalak Upadhyay has asked one question, that we see a lot of children, infants especially, who are absolutely normal, tall for their age. They are obese. Most of them are breastfed, and there is no cause found. And post infancy they suddenly lose their obesity. So what is that? What kind of disorder are we dealing with?
That is absolutely, probably that's physiological, and that's also in the families where you see the family members can be quite hefty as well. See, we use BMI because that's the practical measure we have to assess obesity, but BMI probably is not the accurate measurement of obesity and our weight issues, isn't it? Visceral adiposity and other things matter more than somebody's actual sort of weight. We have seen patients whose BMI is way high, but metabolically completely normal, depending on their ethnicity, And we have seen also South Asian population who BMI may be low, but have all other complications already. So it's quite variable. So if there are families who are members of big, but otherwise fine, in those families, we might see the kids or the babies quite heavy. Then subsequently, once they started walking and running around, and they shed all that extra weight and they're fine. In terms of that, when do we suspect other genetic causes? Of course, if there are other problems like dysmorphic features or learning difficulties or developmental issues, then of course, then you start thinking about genetic causes.
There's one question of use of octreotide in patients with central hypothalamic obesity. Dr. Vani has asked. So, do you have any experience of use of octreotide in such cases with hypothalamic obesity?
No, I have no experience using it. I've used octreotide for other reasons, but not for obesity. No.
Dr. Parvati has asked regarding growth hormone in priority. So how long can it be continued for metabolic benefits?
Yeah, so we obviously all, we all use growth hormone for primarily for the body composition and improving the metabolic profiles until they finish the puberty and growth in puberty. So that's something a standard practice, isn't it?
So, can be continued like as long as?
You mean like as an adult? You mean?
Yeah.
The pediatric.
Parvati's meaning, I guess. Like how long do you give growth hormone for the metabolic benefits if they can afford, like, because growth hormone is not like free of cost.
Absolutely. I mean, you can definitely continue through childhood into adolescence until they finish growth. And whether it's beneficial in adults, I'm not entirely sure, but yeah, at least until they finish growth.
The role of semaglutide and early age can be started, Dr. Kocher.
Sure. As I said,
Dr. Kocher.
Yeah. I think everybody is waiting for semaglutide in adolescents.
Absolutely. And as I said, currently it's not licensed or approved because the data is not out. So the STEP-TEEN study, which is an international study comparing semaglutide in the adolescent age group with placebo, it's recruitment, everything is finished. So they're going to conclude, and probably in early next year, the data will come out. And then hopefully after that, it will be licensed. The patients we use is on an off-licensed basis. And for select patients, like I've got few patients on them with severe complications or diabetes, then we have taken that approach to try because there's no other option to try. But at the moment it is off-licensed, but it's approved for more than 18 years, but not less than 18 years, but might become licensed in probably next year or so.
So if we have any other questions, Dr. IPS Kocher sir has asked that any particular, your observation on who fails on the lifestyle management. I mean, your experience in patient who fail in lifestyle management.
I think maybe we should ask the other way around: who succeeds in lifestyle management? I think because yes, we all talk about lifestyle modification all the time, but we have to also realize we as endocrinologists deal with patients who have got severe obesity. It's again, obesity is batched under one big category, but there is so many subcategories within that, so many different age groups, so many other issues. So if you're talking about genetic obesity or, mild to moderate obesity, early stage where the patients are motivated, want to engage, make some changes, they're confident of making those changes, yes, then lifestyle is the right thing to do and they may see some benefits. Whereas if they've already gone through that, they've tried something, but they failed, and then they get the negative experience. They don't feel confident of making the change anymore. And the parents probably have tried and they failed. And the parents bring a lot of negative experiences of like, I've tried, this doesn't work for me, it doesn't work for our family. Then they're all stuck in this. And then they are in a situation, teenagers, so much happening in their life, the pressures about education, they're growing up as an adult, so many things going on, and they may not be in the right phase to make any changes in their life. So those patients, and when we see them with complications, they're already gone to the severe extreme. and the patients we see, then just lifestyle, that is why we probably don't see much benefit. It has to be done, but we may have to offer something more than just lifestyle, and we may have to combine with some medical therapy, at least to make some change, to give them a little bit confidence that they can achieve some weight loss. And once they've done that, then they may be able to continue the lifestyle for the long term. I don't know if you all agree, or Dr. Shaila and others agree with what I said.
I have just a few patients whom I've started on metformin. It's really rare to start. Every visit, I just insist on lifestyle management. Some have succeeded, like what you said. Some have not succeeded. Some have had really good response. They have lost 8 kg, 10 kgs in 2 months, 3 months. But I need to see them again after a year, how they are maintaining. As long as they come for follow-up, they definitely are in line. Once they lose the track, again, they are back to. So, but definitely, I think this psychotherapy and lifestyle management is what I have been doing till now. I would say 50% results are good.
They listen to you better, Dr. Shaila.
Sorry?
They seem to listen to you better. You're probably very strict.
People usually come for quick fixes, so they just want some kind of medicine. If you tell them that we don't have got any medicine for obesity and this is a lifestyle modification they have to do, then they are really upset by this news.
So there comes your metabolic parameters.
Yeah, so metabolic parameters only.
They are the scary sticks for them.
Yeah, I fully agree with that. I think as a medical person and as a doctor, we sometimes underestimate the power we have, isn't it? So we're going through the complication highly, especially if you show them the dyslipidemia and the other liver.
Let me tell fatty livers are very scary.
I completely agree. Fatty liver is really scares patient and as well as family.
But for that,
now started to
have a deranged liver function test, na? Otherwise.
No, we never tell deranged liver functions, not starry words. We'll just say fatty liver. Fat jam gaya.
just tell them they're going to need a new liver soon.
New liver soon, yeah.
One thing that I have now started to ask, I mean, for last 3 or 4 years, is I ask the parents' weights when they got married, and then I compare their current weights, and when they realize that they have, along with the child, they have also gained so many kilos. So maybe that triggers some thought in their mind that the family has to work together.
And I also tell them all of them should weigh and write when they come for each visit. So the family also are.
Yeah. I think that is important. Absolutely. The whole family engaging with the key. Sometimes the poor child gets blamed, and everybody else is sort of relaxed, but it is the whole family who has to engage, isn't it?
So what I do in my practice is as we write for short stature, we write father's height and mother's height and take out the target height. Similarly, I write the father's weight and mother's weight along with the kid's weight. And then when they come for follow-up, they are not blaming the child directly, because then you have to weigh them and show them that you also didn't do anything. And it's a family therapy. It's never individualized therapy.
Yeah, true. But again, like all that is again, the benefits, like you were saying, when they come back, and whether it is short term or whether it's going to persist in the long term is what we need to see. And some may be motivated, you achieve some weight loss, but then what happens in the long term? So building those healthy habits in the long term will be the key, isn't it?
We have had the other extreme also, like when child had come and when I told you need to lose weight, metabolic parameters and all, then the father very coolly said, no need to worry, doctor. I have had bariatric surgery. My son also will have, so no need to struggle to lose weight. So they also already, for a 14-year-old boy, he had already fixed his treatment.
Yeah, I think that is the problem. When obviously in children, we are going to rely on parents to make those changes. And if they themselves had a lot of different experiences, negative experience, whatever, that is going to play a lot there, isn't it? Whether they're able to make a change or not. And if they don't believe in what we're going to say, they're like, whatever you say, it's not going to work. then they're not going to make those changes.
Correct.
That's why pushing them to come with some solutions or making them to think about why would they want to make the change, or do they really want to, are they really concerned, are they really wanting to make some change, becomes important.
Any more questions, Divya? I think sir has asked about IOTF cutoffs are 23 and 27. Please mention about Payal's presentations.
I think Dr. Raghupati sir has clarified about Payal's presentation, and he has clarified that the IOTF cutoffs are 23 and 27.
Yeah, because she had mentioned different.
Right.
I think we can wind up.
Yeah.
Dr. Divya, over to you.
So we have come to end of the program. I thank all the delegates who have spared time to attend the meeting on a Saturday evening, and to the two invited speakers who have provided us an state-of-the-art or like spectacular lectures, Dr. Khalid Hussain and Dr. Sendil. And also excellent moderators, Dr. Mohan, from whom I think all of us have learned a lot from neonatal diabetes perspective, and Dr. Tushar for sharing his experience as well. I thank Shaila ma'am for taking up this initiative, and it's been going on for the past 1.5 years. And I thank my colleague Hari, and he has been a pillar of support for the last 6 months at least in the conduct of this program. And all the executive members of ISPAE and advisors. I want to thank the events person, RX event, Nirav, and also Ayush for posting all the updates in Facebook and as well as YouTube Live. So please subscribe to YouTube channel of ISPAE and keep a watch for mails regarding the ACES program. And I also request all the delegates to send abstracts of all the interesting cases based on the theme of the meet. So it really helps us a lot to learn from your experience. So thank you all. Have a great weekend.
Thank you, Senthil and Tushar. Bye.
Bye-bye. Thank you.
Good night.